Welcome, curious minds, to another profound journey into the heart of knowledge. I'm your guide, and today we're embarking on an exceptionally thorough deep dive. Our mission, as always, is to take complex, multi-layered information, sift through it, and distill it into clear, actionable, and, dare I say, fascinating insights that you can truly internalize. We're not just scratching the surface here, we're really aiming for a professional-level understanding, a true mastery of our topic today.
That's precisely what we're here to do. Today, we're not simply glancing at a common disease. We are taking a true deep dive into the very nuances of measles, also known as rubeola. Our insights are meticulously drawn from Chapter 205 of the provided source material, which offers an incredibly rich and detailed understanding. For anyone seeking to be genuinely well-informed in public health, mastering this information isn't just important, it's absolutely critical given its history and, its continued global relevance.
And what a topic it is. To give you a sense of its sheer impact, consider this. Before vaccination became widespread, measles was estimated to cause more than 2 million deaths worldwide every single year. 2 million. That's a truly staggering, almost incomprehensible number. Or think about the paradox of this disease. It triggers an incredibly intense immune response, yet that very response can leave the body more vulnerable to other infections for an extended period. It's kind of mind-bending, isn't it? By the end of this deep dive, you, our listener, will not just understand measles. You will emerge with a master-level grasp of its complexities, its history, and its ongoing challenges. So let's get started. Okay, let's unpack this with a foundational understanding. What exactly is measles, also known as rubeola?
Right. So at its core, measles is a highly contagious viral disease. Its clinical presentation is quite distinct. It generally follows a predictable sequence of symptoms. It begins with what's known as a prodromal illness. This is that initial pre-rash phase where the body starts reacting to the virus, but, the characteristic spots haven't appeared yet. During this prodrome, an infected person will typically experience a fever, which can often be quite high, accompanied by a persistent cough, coryza.
Coryza, that's the runny nose, right?
Exactly. That's the medical term for a severe runny nose, often quite watery, and conjunctivitis, which manifests as red, inflamed, or irritated eyes. This specific cluster of symptoms, fever, cough, runny nose, red eyes, is a classic and a crucial warning sign for clinicians, often appearing about 10 days after exposure.
So this distinct sequence of symptoms really helps differentiate measles early on.
Yeah.
And once that prodromal phase runs its course, then comes the hallmark of the disease, the generalized maculopapular rash. But before we delve deeper into that, let's truly grasp the historical impact of measles. It's difficult to overstate the sheer scale of the challenge it once posed to humanity.
Absolutely. The historical record reveals a truly devastating picture. Before the widespread use of measles vaccines, it's estimated that measles caused more than 2 million deaths worldwide each year.
2 million a year. Wow.
Yeah. This isn't merely a statistic. It represents immense suffering, countless lost lives, and a profound societal burden. Imagine entire communities, entire families just being ravaged by what was essentially a common childhood illness back then. This staggering figure underscores the devastating power measles held over populations globally, highlighting why it was once one of the leading causes of death in young children.
That context makes the next part even more remarkable, really. The advent of vaccination marked a monumental turning point, truly one of the greatest global success stories in public health. Through dedicated measles vaccination efforts, there has been incredible progress in reducing global measles incidence, meaning fewer people getting sick, and, critically, a dramatic reduction in mortality rates. Entire regions have achieved what once seemed impossible.
Indeed. A truly monumental achievement in public health was when the World Health Organization, the WHO, declared its region of the Americas to have eliminated endemic measles. That was back in September 2016.
The first region in the world to do that.
It's the very first, yeah. It signified that the measles virus was no longer consistently circulating within those populations. This success in the Americas wasn't just luck. It was the result of a very specific and intensive strategy. It combined widespread vaccination with robust surveillance efforts, meaning actively tracking and responding to any potential cases. A key part of this was the successful Pan American Health Organization, or PAHO, strategy of periodic nationwide measles vaccination campaigns. These are often referred to as supplementary immunization activities, or SIAs. These large-scale focused campaigns, coupled with consistently high levels of routine measles vaccine coverage, created a formidable protective shield across the entire continent.
And the U.S. played a role there, too.
Yeah. Absolutely. In the United States, high-level coverage with 2 doses of the measles vaccine led to the elimination of endemic measles virus transmission back in 2000. And this progress wasn't just confined to the Americas. Significant strides have also been made in sub-Saharan Africa and Asia, largely due to increasing routine measles vaccine coverage and the strategic provision of a crucial second dose of the vaccine through mass campaigns and childhood immunization programs.
And the numbers truly connect the dots, illustrating the profound impact of these efforts. We're talking about lives, real lives saved on a massive scale.
Absolutely. The statistics are genuinely compelling, and they speak volumes about the power of vaccines. From 2000 to 2019, estimated global measles deaths saw an astounding 62% decrease. They plummeted from around 539,000 deaths annually down to 207,500.
That's huge.
It's a massive collective win for global public health. And perhaps even more impactful, measles vaccination prevented an estimated 25.5 million deaths over this exact same period. Just think about that. 25.5 million lives saved by a vaccine. That single statistic truly showcases the transformative, life-saving power of the measles vaccine. It's a testament to what focused global public health initiatives can achieve.
Here's where it gets really interesting, though, showing the constant sort of fragility of these hard-won games. Despite all this incredible progress, we saw a global measles resurgence in 2019. This unfortunately led to the heartbreaking loss of measles elimination status in the region of the Americas and seriously threatened that status in the United States. This isn't just a blip. It highlights a continual, persistent risk that we must remain vigilant against.
Just right.
To put it in stark terms, in 2019, the United States alone reported 1,282 measles cases. That was the highest number of cases since 1992. It's a stark reminder that elimination is a status that must be actively maintained through ongoing vigilance.
And this underscores why collaborative efforts remain absolutely vital even today. The Measles and Rubella Initiative is a prime example of this ongoing work. It's a powerful partnership led by some of the biggest names in global health: the American Red Cross, the UN Foundation, UNICEF, the US CDC, and the WHO. Since its inception back in 2001, this initiative has played a crucial role. It provides essential technical and financial support for routine immunization activities, for critical mass vaccination campaigns, and for strengthening disease surveillance systems in 88 countries worldwide. This ongoing coordinated work is absolutely crucial for maintaining the gains we've made and, more importantly, for addressing new outbreaks as they inevitably arise. It's a continuous, dynamic global effort.
That was an incredible overview of measles' historical impact and the remarkable progress we've made. Now let's go deep into the virus itself. What is its fundamental nature, and what makes it such an incredibly effective pathogen when it comes to spreading through populations?
Okay, let's break down the virology with some precision. The measles virus, scientifically, it's a spherical, non-segmented, single-stranded, negative-sense RNA virus. Essentially, it's a single strand of RNA, its genetic blueprint, enclosed within a protective spherical casing. It belongs to the morbillivirus genus, which is part of the larger Paramyxoviridae family. Now, that family name might ring a bell. It's a group known for spreading through respiratory droplets, which already gives us a clue about its transmission. And what's fascinating here is its origin. Measles was originally a zoonotic infection.
Meaning it jumped from animals.
Exactly. It jumped from animals to humans at some point in history, much like many other significant human pathogens we deal with today. But here's a truly remarkable characteristic for an RNA virus and a massive advantage for us in public health. Despite RNA viruses typically having very high mutation rates, the measles virus is considered antigenically monotypic.
Monotypic, meaning it doesn't change much.
Yeah. Precisely. What that means is that its surface proteins, the very structures that our immune system recognizes to induce protective immunity, have remarkably retained their exact antigenic structure across vast spans of time and geographic distance. This stability is of immense public health significance because it means that measles vaccines developed decades ago from a single strain of the virus remain protective worldwide. You don't need a new measles vaccine every year, for example, unlike, say, the influenza virus, which requires annual reformulation due to its rapid antigenic drift. This monotypicity is a huge advantage in our fight against measles.
Okay, that's a huge plus. But you mentioned a challenge, too.
Right. There's a flip side to its nature that presents a significant logistical challenge for vaccine distribution. The measles virus itself is quite vulnerable in the environment. It's readily killed by ultraviolet light, like sunlight and heat. And crucially, the attenuated measles vaccine viruses, those weakened versions used in the vaccine, they retain these very characteristics. This necessitates what's known as a cold chain for vaccine transport and storage.
The cold chain. keeping it refrigerated constantly.
Exactly. A cold chain is a temperature-controlled supply chain that ensures vaccines remain within a specific, narrow temperature range, typically refrigerated, from the point of manufacture right up to the point of administration. This is a critical logistical consideration, especially in remote or hot climates where maintaining consistent refrigeration can be incredibly difficult. Without a functional cold chain, vaccine potency is rapidly lost, rendering immunization efforts ineffective.
So if that's the virus itself, fragile in some ways, yet remarkably consistent antigenically, let's move to the highly dynamic world of how this virus interacts with human populations. What makes it such a formidable adversary in terms of its ability to spread so effectively?
That's where its epidemiology truly stands out. Measles virus is undeniably one of the most highly contagious, directly transmitted pathogens we know. Its extreme contagiousness is perhaps its most defining epidemiological characteristic. Outbreaks can occur in populations where less than 10% of individuals are susceptible, meaning where 90% or more are already immune.
Less than 10%. Wow, so it finds the gaps incredibly well.
It really does. Think about that. Even a relatively small pocket of unvaccinated individuals can be enough to fuel a significant outbreak because the threshold for herd immunity is so incredibly high, often cited at 95% or even more. Chains of transmission are incredibly common and efficient, particularly among close contacts like household members, school-aged children who are in consistent close proximity, and, significantly, healthcare workers who may be exposed in clinical settings.
And it only infects humans, right? No animals involved anymore.
That's a critical point for eradication efforts, and yes, that distinguishes measles from many other viruses. There are no latent or persistent measles virus infections that result in prolonged contagiousness, meaning once you recover, you're not a long-term carrier, unlike some other viruses, nor are there animal reservoirs for the virus. This is a huge advantage for eradication. Because there are no animal reservoirs or long-term human carriers, measles virus can only be maintained in human populations by an unbroken chain of acute infections.
Which means it needs new susceptible people all the time.
Exactly. It requires a continuous supply of susceptible individuals. And who makes up the bulk of these new susceptible individuals? Newborns. Once the passively acquired maternal antibody they receive from their mothers during pregnancy is lost, which typically happens by around 6 to 9 months of age, these unvaccinated infants then become the next link in the chain, vulnerable to infection.
So we're talking about an almost perfect self-sustaining transmission machine, as long as there are susceptible individuals. Given that, what are the typical patterns of measles transmission we see in populations, both annually and over longer periods?
Well, endemic measles has a very typical temporal pattern. It's characterized by yearly seasonal epidemics. These are then superimposed on longer epidemic cycles that occur every 2 to 5 years, or sometimes even longer. In temperate climates, we typically see annual measles outbreaks occurring in the late winter and early spring.
Why then? Schools. Weather.
Probably a combination of factors. First, social networks facilitating transmission, like the close congregation of children at school or in childcare settings after holiday breaks, certainly play a significant role. Second, environmental factors, such as lower humidity and colder temperatures, might favor the viability and transmission of the measles virus in the air. Makes it easier for those droplets to hang around. During what we call interepidemic periods, when major outbreaks aren't occurring, measles cases still continue to occur even in large populations, but at a significantly lower incidence. The longer epidemic cycles, those occurring every several years, result from the gradual accumulation of susceptible persons over successive birth cohorts.
So the pool of vulnerable people builds up again.
Exactly. As more children are born and grow up without being exposed to the virus or vaccinated, the pool of susceptible individuals grows. Once this pool reaches a critical mass, a subsequent outbreak then causes a rapid decline in the number of susceptibles, effectively burning through that accumulated vulnerability. That then leads to a period of lower incidence before the cycle begins anew.
And it spreads incredibly efficiently within those vulnerable groups.
Oh, absolutely. To illustrate just how efficient this virus is at spreading among those who are unprotected, secondary attack rates among susceptible household and institutional contacts generally exceed 90%.
90%. So if one person gets it in a house.
Pretty much everyone else who isn't immune is likely to get it too. Now, the average age at which measles occurs isn't static. It depends heavily on several factors. The rates of contact with infected persons, how quickly protective maternal antibodies decline in infants, and, most critically, vaccine coverage within a population. In densely populated urban settings with low-level vaccination coverage, measles is predominantly a disease of infants and young children. The cumulative incidence, or the proportion of children who have acquired measles, can reach as high as 50% by just 1 year of age. And significantly, a large proportion of these children acquire measles before 9 months of age, which is often the age of routine vaccination in many countries, according to WHO guidelines.
But that changes with higher vaccination rates.
Yes, it does. As measles vaccine coverage increases, or as population density decreases, the age distribution of cases tends to shift toward older children. In these situations, measles cases will predominantly be seen in school-age children. Infants and very young children, while still susceptible if unprotected by vaccination, are simply not exposed to the measles virus at a rate high enough to cause a heavy disease burden in their age group. And if vaccination coverage increases even further, the age distribution of cases can be shifted into adolescence and adulthood. This is a pattern that has been observed in measles outbreaks in the United States, for example, and it highlights the necessity for targeted measles vaccination programs for these older age groups, perhaps as part of school entry requirements or travel health advice. Some countries, interestingly, have what's called a bimodal distribution, where measles cases predominantly occur in both very young infants and also in adults, representing different susceptible populations within the same country.
This shift in age distribution and the sheer contagiousness of the virus really brings us to what gets really important for public health strategy. The infectious period, for example, poses a massive challenge for control.
It truly does. Persons with measles are infectious for several days before and after the onset of the rash. This is critical because this is the period when levels of measles virus in the blood and body fluids are highest, and crucially, it's when symptoms like cough, coryza, and sneezing are most severe, all of which facilitate virus spread through respiratory droplets.
So people are spreading it before they even know they have measles or before it looks like measles.
Exactly. The contagiousness of measles before the onset of recognizable disease is a significant hurdle. It inherently hinders the effectiveness of isolation measures, making containment much, much harder than diseases where contagiousness begins only after symptoms are obvious. Furthermore, viral shedding, meaning the release of virus particles, can be prolonged in children with impaired cell-mediated immunity, which of course increases their risk of transmitting the virus to others.
And healthcare settings are a particular risk.
Yes, unfortunately, medical settings are well-recognized sites of measles virus transmission. This is because children, especially, may present to healthcare facilities during that prodromal phase, the period before the rash when the diagnosis isn't obvious. But they are already highly infectious. This means they are likely to infect susceptible contacts in waiting rooms or examination rooms. Healthcare workers themselves can acquire measles from these infected children and then, in turn, transmit the measles virus to other patients or colleagues. This creates a serious risk for vulnerable populations within hospitals. Therefore, implementing specific control measures in healthcare settings is crucial. These include things like placing suspected measles patients in airborne infection isolation rooms with negative pressure, ensuring staff wear N95 masks, rigorous contact tracing of exposed individuals, and documenting healthcare workers' immunity to measles, either through proof of 2 doses of vaccine or antibody tests.
It's clear that epidemiology directly connects to broader societal challenges. And what's particularly fascinating here is how success itself can paradoxically breed new challenges, like complacency.
That's a crucial observation, and it's a dynamic we see across various public health successes. As efforts at measles control become increasingly successful and the disease becomes rarer in a given population, public perceptions of the risk of measles as a severe, life-threatening disease tend to diminish. The memory of its devastating impact fades for newer generations. These concerns about the disease itself are then, quite frequently, replaced by concerns about possible adverse events associated with the measles vaccine. As a direct consequence of the shift in public perception, numerous measles outbreaks have unfortunately occurred, driven by opposition to vaccination based on religious or philosophical grounds, or, critically, on unfounded fears of serious adverse events associated with the vaccine. This raises an important question for public health professionals and communicators alike. How do we effectively and continuously communicate scientific understanding and the very real risks of a disease when public perception shifts away from the lived reality of its historical burden? It's a constant battle against misinformation and complacency.
Now that we understand how the virus spreads and its epidemiological patterns, let's go deep into what happens once it actually enters your body. How does measles wreak its unique havoc internally, progressing from initial infection to full-blown illness?
Okay, let's embark on a detailed step-by-step walkthrough of the pathogenesis, the process of how the disease develops. Measles virus is primarily transmitted by respiratory droplets exchanged over short distances, typically within about 6 feet, when an infected person coughs or sneezes. Less commonly, it can also be transmitted by small particle aerosols that are light enough to remain suspended in the air for longer periods, traveling further.
Airborne transmission.
Yes, airborne transmission appears to be particularly important in certain enclosed settings like schools, doctors' offices, hospitals, and other public places where people congregate closely. While less common, the virus can also be transmitted by direct contact with infected secretions like saliva or nasal discharge. But it doesn't survive for long on fomites, meaning inanimate objects like doorknobs or surfaces.
Okay, so once it gets in, what happens? How long does it take?
Right. Once exposed, the incubation period for measles, the time from infection to the first symptoms, is approximately 10 days until the onset of fever and about 14 days until the rash appears. This period can be slightly shorter in infants, maybe around 7 days, and potentially longer, up to 3 weeks in adults. Infection is initiated when the measles virus is deposited in the respiratory tract, the nose, throat, airways, or in the oropharynx, or even directly on the conjunctivae, those membranes lining the eyelids and covering the white part of the eye. From there, the virus begins its journey.
Where does it go first?
During the first 2 to 4 days after infection, the measles virus isn't just sitting idle. It proliferates locally within the respiratory mucosa. It preferentially infects and replicates within specific immune cells, primarily dendritic cells and lymphocytes. From this initial site, the virus then strategically spreads to the draining lymph nodes, which are key components of the immune system. After this regional replication, the virus then enters the bloodstream. This occurs through infected lymphocytes, which essentially act as Trojan horses carrying the virus into the circulation, producing what is called the primary viremia.
Viremia means virus in the blood, right?
Exactly. This primary viremia effectively disseminates the infection throughout the reticuloendothelial system, a diffuse network of cells and tissues found throughout the body, including the spleen, liver, and other lymphatic tissues. This is shown clearly in figure 2051A from our source. But the virus doesn't stop there. Further rounds of replication occur within these disseminated sites, which then leads to a secondary viremia. This phase typically begins around 5 to 7 days after the initial infection and results in the widespread dissemination of the measles virus throughout virtually the entire body.
So it really gets everywhere.
It does. And it's the replication of the measles virus in these various target organs, in conjunction with the host developing immune response, that is responsible for the characteristic signs and symptoms of measles. These symptoms, which we'll discuss in more detail, typically occur 8 to 12 days after infection and mark the crucial end of that initial silent incubation period. This whole progression is laid out in figure 2051B.
So it's a systemic invasion, not just a localized infection. And when the virus is spreading throughout the body and replicating, our body naturally fights back. How exactly does our incredibly complex immune system respond to this viral invasion? And what are the consequences of that fight?
Right, the host immune responses to measles virus are absolutely essential. They are critical for several key outcomes: for achieving viral clearance, getting rid of the virus, for clinical recovery, allowing the person to get well, and crucially, for the establishment of long-term immunity, which protects against future infections. This whole immune process is depicted in figure 2051C in our source. Early in the disease, during that prodromal phase, our body deploys its nonspecific or innate immune responses. This involves activating natural killer cells, immune cells that can kill virus-infected cells, and increasing production of various antiviral proteins.
The first line of defense.
Exactly. Following these initial innate responses, the adaptive immune responses kick in, which are highly specific to the measles virus. These consist of both measles virus-specific antibody responses and cellular responses involving T lymphocytes. The protective efficacy of antibodies to measles virus is clearly illustrated by a couple of examples. First, the immunity conferred to infants through passively acquired maternal antibodies passed from mother to baby. And second, the protection seen in exposed, susceptible individuals after they receive an administration of anti-measles virus immunoglobulin, which is basically a concentrated dose of protective antibodies.
And there are different types of antibodies.
Yes. The first measles virus-specific antibodies produced after infection are of the IgM subtype. These are the immediate responders. Following this initial IgM burst, there's a switch to predominantly IgG1 and IgG3 isotypes, which are the longer-lasting antibodies responsible for sustained protection. The IgM antibody response is typically absent following re-exposure or revaccination, and this fact serves as a crucial marker of primary acute infection. So if you see measles IgM in a lab test, it almost certainly means a recent first-time infection.
What about the cellular side, T cells?
The importance of cellular immunity, specifically involving T lymphocytes, to measles virus cannot be overstated. This is powerfully demonstrated by comparing two scenarios. Children with a gamma globulinemia, a congenital inability to produce antibodies, are remarkably able to fully recover from measles. This tells us that cellular immunity alone can clear the virus. This contrasts sharply with children who have severe defects in T lymphocyte function. These individuals often develop severe or even fatal disease, underscoring the critical role of T cells. The initial predominant Th1 response, characterized by interferon gamma, is essential for viral clearance. Later, a Th2 response, characterized by interleukin-4, promotes the development of those crucial measles virus-specific antibodies that are critical for protection against reinfection.
And this immunity lasts a long time.
Generally, yes. The duration of protective immunity following wild-type measles virus infection is thought to be lifelong. This robust and enduring immunity is a key feature. Immunologic memory to measles virus includes both the continued production of specific antibodies and, crucially, the ongoing circulation of specific CD4+ and CD8+ T lymphocytes memory cells ready to respond if you're re-exposed.
This is truly fascinating, the intricate dance between the virus and our defenses, but here's where it gets really interesting. And, frankly, a profound and counterintuitive effect of measles on the immune system that is a critical insight for anyone looking to truly master this subject.
Indeed, this is perhaps one of the most insidious aspects of measles and a critical insight for professionals. While the intense immune responses induced by measles virus infection are essential for clearing the virus, they are paradoxically associated with depressed responses to other antigens. This means that after a measles infection, the immune system becomes less effective at responding to other pathogens, whether previously encountered bacteria and viruses or even new ones.
So it weakens your immunity overall, even after you recover from measles.
Exactly. This state of immune suppression can last for weeks to months, and remarkably, some evidence suggests it might even last for years beyond the resolution of the acute illness. This profound post-measles immune suppression significantly enhances an individual's susceptibility to secondary infections with bacteria and other viruses. These secondary infections aren't minor. They frequently cause severe conditions like pneumonia and diarrhea, and critically, they are responsible for a substantial proportion of measles-related morbidity and deaths. For example, delayed type hypersensitivity responses to recall antigens, like tuberculin, are markedly suppressed. The body's ability to fight certain infections like TB is severely hampered. Furthermore, cellular and humoral responses, both T-cell and antibody responses, to new antigens are also impaired.
What are the real-world consequences?
They're striking. There have been documented cases of reactivation of tuberculosis in individuals who previously had latent TB, and even remission of autoimmune diseases after measles, both attributed to this immune suppression. But perhaps most importantly, and this is a crucial takeaway, the infection results in the depletion of circulating antibodies against previously encountered viruses and bacteria.
It wipes out memory of other infections.
It severely impairs immunological memory. Your body effectively forgets some of its prior immunity to other common pathogens. This mechanism may well explain why child morbidity and mortality can remain increased for more than 2 years after a measles infection. It makes children vulnerable long after they appear to have recovered from the acute illness. It's like an immunological amnesia that leaves the body incredibly fragile.
With that incredibly deep understanding of how measles operates internally and the profound impact it has on the immune system, what does it look like when someone actually has it? And how do clinicians confirm and then manage this incredibly complex disease?
Right. In most people, the signs and symptoms of measles are indeed highly characteristic and follow that predictable course we mentioned, much as depicted in Figure 205, Drill 1B. It begins with the prodromal phase, typically starting about 10 days after exposure. Patients will develop a fever and a general feeling of malaise, just feeling unwell. This is then followed by that classic triad of symptoms: a severe, persistent cough, coryza, that profuse runny nose, and conjunctivitis, red, watery eyes. These initial signs and symptoms will steadily increase in severity over about 4 days.
And then comes the key sign before the rash.
Exactly. Koplik spots. These distinctive lesions typically develop on the buccal mucosa, the inner lining of the cheeks, usually opposite the lower molars, about 2 days before the characteristic measles rash makes its appearance. Koplik spots consist of bluish-white dots, very small, about 1 millimeter in diameter, each surrounded by a noticeable ring of redness, or erythema. They are considered pathognomonic of measles.
Pathognomonic, meaning only measles cause them.
Pretty much, yes. They are uniquely specific to this disease. They usually appear first on that buccal mucosa, but they rapidly increase in number and can involve the entire inner cheek lining. Interestingly, they tend to fade just as the rash starts.
Okay, so after complex spots, the rash begins. Tell us about that.
The hallmark of measles, the characteristic rash, begins approximately 2 weeks after infection. This timing is significant because it coincides with when the clinical manifestations are most severe, and it signals the host's robust immune response kicking in against the replicating virus. The rash itself begins as erythematous macules flat, red spots, first appearing subtly behind the ears and then on the neck and along the hairline. From there, it follows a classic progression. It spreads downwards to involve the face, then the trunk and the arms, with involvement of the legs and feet typically by the end of the second day of the rash. As the rash progresses, areas of confluent rash appear, particularly on the trunk and extremities, meaning the spots merge together to form larger red patches. In some cases, tiny red spots called petechiae, caused by bleeding under the skin, may also be present.
And then it fades.
Yes, the rash fades slowly, following the same order of progression as it appeared, usually beginning on the third or fourth day after its onset. In some cases, particularly in undernourished children, the resolution of the rash may be followed by desquamation, which is a peeling or flaking of the skin. In addition to these classic signs, patients may also experience headache, abdominal pain, vomiting, diarrhea, and myalgia, or muscle pain.
Does it always look like this? Or are there variations?
That's important. The presentation can vary, especially in certain populations. Because the characteristic rash is a direct consequence of the cellular immune response, it may not develop or may be severely weakened in persons with impaired cellular immunity. This includes individuals with conditions like AIDS or those undergoing cancer chemotherapy. These immunocompromised individuals have a significantly high case fatality rate from measles, and they frequently develop a severe lung inflammation called giant cell pneumonitis, caused by the virus replicating directly in the lungs. Similarly, T lymphocyte defects due to other causes are also associated with increased severity.
And there was that historical atypical measles.
Right, the atypical measles syndrome. This was a specific phenomenon related to an early inactivated vaccine. It occurred in recipients of a formalin inactivated measles vaccine used briefly in the US and Canada in the 60s. If these individuals were subsequently exposed to wild-type measles virus, they'd develop an unusual presentation. The atypical rash began on the palms and soles and spread inwards towards the trunk, crucially sparing the face. The rash was initially red and spotty, but often progressed to blisters or bleeding lesions. This historical syndrome really highlights the critical importance of proper vaccine formulation.
Given the array of other rash-causing illnesses out there, how do clinicians effectively differentiate measles from all those other conditions? What are the key distinctions they're looking for?
Yeah, the process of differential diagnosis is absolutely crucial here. The list of things that can cause fever, rash, and conjunctivitis is pretty broad. It includes rubella, Kawasaki disease, infectious mononucleosis, roseola, scarlet fever, Rocky Mountain spotted fever, various enterovirus or adenovirus infections, and even drug sensitivities. Clinicians must carefully weigh the symptoms to narrow it down.
What are some key differences?
Well, for instance, rubella, or German measles, is generally a milder illness compared to measles. Crucially, it typically occurs without that severe cough, and it presents with distinctive swollen lymph nodes, especially behind the ears and neck, which isn't as prominent in measles. Another important one is roseola, or exanthum subitum. The rash of roseola characteristically appears after the fever has subsided. With measles, remember, the rash hits when the fever and other symptoms are at their peak. And for infectious mononucleosis, while it can cause fever and a rash, lab tests would show an atypical lymphocytosis, an unusual white blood cell picture, which contrasts sharply with the leukopenia, or low white blood cell count commonly seen in kids with measles. These specific clinical markers are vital.
So how do you make a definitive diagnosis, especially when the clinical picture isn't perfectly clear or in settings where measles isn't commonly seen? What are the laboratory methods involved?
Right. While measles can often be diagnosed clinically by experienced clinicians, especially during outbreaks, it can be trickier in certain scenarios. Complex spots are super helpful because they appear early and are pathognomonic. But clinical diagnosis becomes more difficult, say, during the prodromal illness before the rash, or when the rash is weakened by antibodies or prior immunization, or when the rash is absent or delayed in immunocompromised or severely malnourished kids, and definitely in regions where measles is very rare. For surveillance, the WHO has a clinical case definition: rash for at least 3 days, fever over 101 degrees air, and cough, chorusy, or conjunctivitis. But, except during big outbreaks, diagnosis almost always needs lab confirmation.
What's the main lab test?
Serology is the most common, looking for antibodies in the blood. Detecting measles-specific IgM in a single serum or oral fluid sample is considered diagnostic of acute infection. Alternatively, seeing a fourfold or greater increase in measles-specific IgG antibody levels between an early acute sample and a later convalescent sample is also diagnostic. In healthy people, antibodies usually show up within 1 to 3 days of the rash onset and peak in 2 to 4 weeks. IgM might take 4 or 5 days or more after the rash starts to be detectable, and it usually disappears within 4 to 8 weeks.
Are there different ways to measure antibodies?
Yes, neutralization tests are very sensitive and specific, and they correlate well with immunity, but they're complex and expensive. They involve growing the virus in cell culture, so they aren't routine. Commercially available enzyme immunoassays, or EIAs, are used most often because they're practical. Beyond serology, you can also diagnose measles by isolating the virus itself in cell culture, from respiratory secretions, swabs, blood, or urine, or by directly detecting characteristic giant cells in secretions or tissues.
What about newer molecular tests?
Absolutely. Molecular detection, specifically reverse transcription, polymerase chain reaction, or RT-PCR, is extremely sensitive and specific for detecting measles virus RNA in clinical samples. This uses primers targeted to highly conserved parts of the virus's genes. RT-PCR isn't just diagnostic, it also allows for identifying and characterizing specific measles virus genotypes. This is incredibly valuable for molecular epidemiology, tracking the spread of specific strains during outbreaks. And critically, RT-PCR can distinguish between wild-type virus strains causing natural infection and vaccine virus strains. That distinction is absolutely vital for public health investigations.
Once diagnosed, what's the treatment? Is there a specific antiviral drug that targets measles, or is it more about managing the illness and its complications?
Unfortunately, there is no specific antiviral therapy that directly targets the measles virus itself. Unlike some other viruses, we don't have a drug that effectively kills measles. Therefore, treatment for measles primarily consists of general supportive measures, things like ensuring the patient stays well hydrated, especially with fever or diarrhea, and giving antipyretics like acetaminophen to manage the fever and discomfort.
What about the secondary infections you mentioned?
That's a critical aspect of management. Because of that immune suppression, patients are highly susceptible to secondary bacterial infections, which are a major cause of illness and death. So prompt antibiotic treatment is essential for patients who show clinical evidence of a bacterial infection like pneumonia or otitis media, ear infection. Common culprits are Streptococcus pneumonia and Haemophilus influenza type B. Interestingly, vaccines against those bacteria probably help lower the incidence of secondary infections following measles.
Is there anything else that helps significantly?
Yes, vitamin A. It's remarkably effective for treating measles and can significantly reduce rates of morbidity and mortality. The WHO has specific recommendations. Administer once daily doses of 200,000 IUs of vitamin A for 2 consecutive days to all children with measles aged 12 months or older. Lower doses are for younger kids. 100,000 IUs daily for 6-12 months old and 50,000 IU daily for under 6 months. A third dose is recommended 2 to 4 weeks later for kids with signs of vitamin A deficiency.
Even in places like the U.S.?
That's a good point. While vitamin A deficiency isn't a huge public health problem in the U.S. generally, many American children who do get measles actually have low serum levels of vitamin A, and these children tend to have worse outcomes. So the American Academy of Pediatrics, AAP, recommends considering 2 consecutive daily doses of vitamin A for children hospitalized with measles or its complications. Also for kids who are immunodeficient, have eye signs of deficiency, impaired absorption, severe malnutrition, or recently immigrated from high mortality areas. Both injectable and oral forms are available.
Any other potential treatments?
Well, there have been anecdotal reports about using the antiviral drug ribavirin for severe measles in pregnant or immunocompromised patients who recovered. However, it's crucial to note that the clinical benefits of ribavirin in measles haven't been conclusively demonstrated in proper clinical trials. So it's not a standard or proven therapy, more of an in specific severe cases, maybe consideration.
So beyond the acute illness itself, What are the lasting dangers or more severe outcomes someone might face if they contract measles? And what's the long-term outlook or prognosis for someone who goes through this ordeal?
Yeah, the complications of measles are a major concern, definitely extending beyond the initial rash and fever. Most complications involve the respiratory tract. These can be effects of the measles virus replication itself or secondary bacterial infections. For instance, croup, that acute laryngotracheobronchitis, can happen during measles, especially in young kids, and can cause serious airway obstruction. And a more severe lung inflammation, giant cell pneumonitis, can develop in immunocompromised children, including those with HIV, due to the measles virus replicating extensively in their lungs. Also, many children with measles develop diarrhea, which is particularly problematic as it contributes to undernutrition, making them even more vulnerable.
But the biggest threat comes from those secondary bacterial infections due to immune suppression.
Exactly. Most of the severe complications result from secondary bacterial infections of the respiratory tract. These are directly attributable to that profound immune suppression that lasts for weeks, months, maybe even years after the acute illness. Otitis media, ear infection, and bronchial pneumonia, lung infection, are the most common. Common bacteria like S. pneumonia, H. influenza type B, or Staphylococcus are often involved. A key clinical sign suggesting a secondary bacterial infection is if the fever comes back, or if it fails to go down even after the rash appears. That suggests something else, often bacterial, is going on.
What about brain complications? Those sound particularly scary.
They are, though thankfully rare. There are a few types involving the central nervous system, CNS. One is post-measles encephalomyelitis. This complicates about 1 in 1,000 cases, mainly affecting older children and adults. It usually happens within 2 weeks of the rash and causes fever, seizures, and various neurological problems. What's fascinating here is that it's thought to be an autoimmune disorder.
Autoimmune. Not the virus directly in the brain.
Correct. The evidence like finding damage to the myelin sheath around nerves, periventricular demyelination, immune responses to myelin protein, and crucially, the absence of measles virus in the brain strongly suggests it's triggered by the infection, causing the immune system to attack the brain, rather than the virus directly infecting brain tissue. In stark contrast, other CNS complications are caused by persistent measles virus infection in the brain itself. Measles inclusion body encephalitis, or MIBE, is rare but fatal, affecting individuals with defective cellular immunity, typically months after infection. And then there's subacute sclerosing encephalitis, or SSPE. This is probably the most devastating CNS complication.
What happens with SSPE?
It's also caused by persistent measles virus infection, but it's a slowly progressive disease. It features severe seizures and a relentless decline in cognitive and motor functions. Tragically, death usually occurs 5 to 15 years after the initial measles infection. SSP most often develops in persons who were infected with measles virus when they were very young, less than 2 years of age. It really underscores the potential for lifelong, insidious danger, even from a seemingly recovered childhood infection.
So understanding these potentially devastating complications, what does this all mean for someone who contracts measles? What's their prognosis, and how does vaccination truly impact that outlook?
Well, the good news is that most people with measles do recover, and when they do, they generally develop lifelong protective immunity. They won't get it again. However, the measles case fatality proportion, the percentage who die, varies significantly. It depends on critical factors like the average age of infection in a population, the nutritional and immune status of the people, measles vaccine coverage rates, and very importantly, access to healthcare.
So outcomes vary hugely around the world.
Hugely. Among previously vaccinated persons who still get infected, these are usually vaccine failures, the disease is typically much less severe, and importantly, their mortality rates are significantly lower than unvaccinated individuals. This shows the vaccine still offers protection, even if it doesn't prevent infection entirely. To give you a stark contrast, in developed countries with good healthcare and high vaccination rates, fewer than 1 in 1,000 children with measles dies. But in endemic areas of sub-Saharan Africa where healthcare access and nutrition are challenging, the case fatality proportion can be 5 to 10% or even higher. And the situation is even worse in places like refugee camps or among internally displaced populations. Measles is a major killer there, with case fatality proportions reported as high as 20 to 30%. It's just tragic, reflecting the severe impact of poor living conditions and limited health care.
This raises an incredibly important question. If measles is so devastating, how do we effectively prevent it? Let's dive into the core prevention strategies, both passive, for immediate short-term protection, and active, the cornerstone of long-term immunity.
Okay, let's start with passive immunization. which provides immediate, though temporary, protection. This involved using human immunoglobulin, or IG. When given shortly after exposure to measles virus, human immunoglobulin can significantly lessen the severity of the illness or even prevent it altogether. In immunocompetent people, giving IG within 72 hours of exposure usually prevents infection and almost always prevents clinical illness. Even if given up to 6 days after exposure, IG can still prevent or modify the disease.
Who should get this?
Prophylaxis with immunoglobulin is specifically recommended for susceptible household and hospital contacts who are at particular risk of developing severe measles. This includes key groups, especially children under 1-year-old, immunocompromised persons, including HIV-infected individuals, even if previously vaccinated, and pregnant women. It's important to remember that most infants under 6 months are usually partially or completely protected by maternal antibodies. But infants born to mothers without immunity, or whose antibodies have waned, should receive IG if exposed. And if measles is diagnosed in a household, all unimmunized children in that household should get immunoglobulin because the spread is so likely.
How is it given?
The recommended dose is 0.25 millimolar per kilogram of body weight, given intramuscularly. For immunocompromised persons, it's a higher dose, 0.5 millimolar per kilogram. There's a maximum total dose of 15 millimol. It's also worth noting that intravenous immunoglobulin, IVIG, also contains measles antibodies. A usual dose of 100-400 ml/kg generally provides adequate prophylaxis for exposures occurring up to 3 weeks or more after the IVIG infusion.
Now, let's move to the true cornerstone of long-term prevention. Active immunization, which means vaccination. How did this life-saving vaccine come about, and what makes it so effective and enduring?
The history of the measles vaccine is really a triumph of medical science. The first live attenuated measles vaccine was developed by passing the original Edmundston strain of the virus through chick embryo cells multiple times. This weakened it, producing the Edmundston B virus, licensed in 1963 in the U.S. Further passages of Edmundston B produced the even more attenuated Schwartz vaccine strain, which is now the standard in much of the world. In the United States, the Moreton strain, more attenuated Enders, was licensed in 1968 and is currently used. Genetically, the Moreton-Schwartz strains are identical.
And maintaining the cold chain is vital for these live vaccines.
Absolutely vital. Lyophilized or freeze-dried measles vaccines are relatively stable in that powder form. But once you reconstitute them with liquid, they rapidly lose potency. Live attenuated measles vaccines are easily inactivated by light and heat. A reconstituted vaccine can lose about half its potency at room temperature, 20 degrees C, and almost all of it at body temperature, 37 degrees, within just an hour. So that stringent cold chain must be maintained before and after reconstitution. It's a critical logistical challenge, especially in resource-limited settings.
How quickly does the vaccine work?
Antibodies typically first appear around 12 to 15 days after vaccination, and their levels peak at 1 to 3 months. Measles vaccines are often combined with other live attenuated virus vaccines to simplify schedules. The most common is MMR measles, mumps, and rubella, and sometimes MMRV, which adds varicella, chickenpox.
What's the best age to get vaccinated?
The recommended age for the first dose varies a bit globally, usually from 6 to 15 months. This age range represents a careful balance. You want the age when the vaccine is most effective at inducing immunity, seroconversion, but you also want to protect infants before they're likely to get infected naturally. The effectiveness is excellent. About 85% of children develop protective antibodies after vaccination at 9 months, and that rises to 95% at 12 months. Minor childhood illnesses around the time of vaccination might slightly reduce the immune response, but they're generally not a reason to delay vaccination.
What about vaccination for people with HIV?
Measles vaccines have been shown to be generally well-tolerated and immunogenic. They work in HIV-1 infected children and adults, although their antibody levels might decline faster. Because natural measles can be so severe in HIV-infected children, routine measles vaccination is recommended for them unless they are severely immunocompromised. However, measles vaccination is contraindicated, should not be given to individuals with other severe deficiencies of cellular immunity. There's a rare risk they could get progressive disease from the vaccine virus itself.
How long does vaccine immunity last?
It's remarkably long-lasting, at least several decades, if not longer, possibly lifelong for many. While rates of secondary vaccine failure getting measles despite being vaccinated have been estimated around 5%, maybe 10, 15 years after immunization, these rates are probably lower when vaccination happens after 12 months of age. And what's fascinating, even if antibody levels decrease over time, it doesn't necessarily mean complete loss of protection. Usually, a secondary immune response kicks in very rapidly after re-exposure to the wild virus, boosting antibody levels quickly without causing clinical illness. It shows the vaccine creates robust immune memory.
That's a comprehensive overview of the vaccine itself. This then naturally raises an important question, especially in light of past controversies. What about vaccine safety? How can we be sure it's safe?
This is an incredibly important area, and the evidence is very clear. Standard doses of currently licensed measles vaccines are overwhelmingly safe for immunocompetent children and adults. Like any medical intervention, there can be side effects, but they are generally mild and temporary. About 5% of recipients might get a fever up to 103 degrees Fahrenheit. Around 2% might develop a transient mild rash. More rarely, mild temporary thrombocytopenia, a low platelet count, has been reported, about one case per 40,000 doses of MMR vaccine.
And the MMR autism controversy.
Right, that needs direct addressing. Since the publication of a flawed report back in 1998 that falsely hypothesized a link between MMR vaccine and a syndrome of autism and intestinal inflammation, there's been a lot of public focus on this. The events following that report tragically led to lower vaccine coverage, especially in the UK, and they offer really important lessons about misinterpreting evidence and communicating science. The original publication that caused all the concern was just a small case series describing 12 children. 9 had autism. In 8 of the 12 cases, the parents simply associated the onset of developmental delay with the timing of the MMR vaccination.
Association, not causation.
Exactly. This simple temporal association was profoundly misinterpreted and misrepresented as a possible causal relationship. The scientific community responded with overwhelming evidence. Extensive reviews and numerous large, rigorous epidemiological studies were done independently worldwide. These studies conclusively and unequivocally refuted any evidence of a causal relationship between MMR vaccination and autism. The original paper was eventually retracted, and the lead author lost his medical license. This whole episode highlights the critical importance of rigorous science and proper data interpretation, but also the dangerous potential for misinformation to damage public health globally. The scientific consensus, based on decades of research and millions of doses, is crystal clear. The MMR vaccine does not cause autism.
After understanding so much about measles, from its fundamental biology and pathogenesis to its devastating clinical picture, effective treatment, and powerful prevention strategies, what does the future hold? Is global eradication of measles a realistic and achievable goal?
Well, the remarkable progress in global measles control has certainly renewed discussions and optimism around the feasibility of measles eradication. When we compare it to other eradication efforts, measles presents both favorable and unfavorable aspects. Compared to polio, for instance, measles eradication won't face challenges from prolonged shedding of potentially infectious vaccine viruses or from environmental reservoirs of the virus.
So that's an advantage for measles.
It's a significant advantage, yes. It simplifies the target. It's just about stopping human-to-human transmission. However, when we compare measles eradication to the historic success of smallpox eradication, measles presents some unique difficulties. Firstly, much higher levels of population immunity will be needed to truly interrupt measles transmission globally. Measles is simply far more contagious than smallpox was. Secondly, achieving that widespread coverage requires more highly skilled healthcare workers to administer the vaccines effectively, manage that cold chain, and reach everyone. Finally, and crucially, containment efforts like finding cases quickly and vaccinating contacts, ring vaccination, will be significantly harder for measles.
Because it's infectious before the rash appears.
Precisely. That pre-rash infectivity makes contact tracing and isolation much harder and less effective as a primary containment strategy compared to smallpox, where symptoms were obvious before peak infectivity. On a more optimistic note, new tools are on the horizon that could greatly facilitate future efforts. Innovations such as microneedle patches for delivering measles vaccine could revolutionize mass vaccination campaigns.
Microneedle patches. How would they help?
They could be simpler to administer, possibly less painful, and could significantly help vaccinate hard-to-reach children, like those in remote rural areas where traditional needle and syringe campaigns are incredibly difficult logistically. But despite enormous progress, and despite having a highly effective vaccine, measles remains a leading vaccine-preventable cause of childhood mortality worldwide. And as we saw with the 2019 resurgence, it continues to cause outbreaks even in highly industrialized nations, particularly in communities with low vaccination coverage rates. This underscores that while eradication is the goal, the fight is far from over, and continued vigilance and effort are absolutely paramount. Hashtag tag tagged outro auto.
We've truly gone deep today, covering everything from the measles virus's inner workings, its fascinating but insidious pathogenesis, to its historical global impact, the profound effects of its immune suppression, and the complex dance between the virus, our immune system, and concerted public health efforts. You now truly have a master-level understanding of this disease, its history, its present, and its potential future.
What's fascinating here, I think, is that while measles is a disease we understand remarkably well, and against which we possess incredibly effective tools like a safe and potent vaccine, its continued presence in outbreaks reminds us that scientific knowledge alone isn't always enough to solve a global health challenge.
So what does this all mean for you, the well-informed learner, on a broader scale? Consider this. Despite the monumental scientific triumph of the measles vaccine, why do we still face these resurgences, even in highly developed nations that had achieved elimination status? What broader societal factors beyond just the virus itself, beyond the mere existence of a vaccine, do you think are the ultimate determinants in achieving or failing to achieve global measles eradication? This raises an important question about the ongoing role of public education, the erosion or building of trust in scientific institutions, and the enduring challenge of equitable access to health resources across the globe. It's a question of human behavior, social dynamics, and political will, perhaps just as much as it is of virology. Thank you for joining us on this deep dive.